Okay. All right. Ultrasonics, instrumentation, root morphology, instrumentation. Did everyone bring their reference cards? Great, great. And I heard through the grapevine that a few of you helped Mrs. Williams last night with identifying the teeth, and she was very impressed. Very impressed. So she said, thank you. And host modulation. So let's start off with, let's finish last week's lecture. We didn't finish on a couple of the control release products. What are control release devices are available for periodontal therapy? What are the benefits of a control release device? Now, you've all had a chance in clinic to work with Arrestin, correct? Okay, so let's discuss Arrestin. You did it on the little Typodon, the perio Typodon?
Yeah.
Yeah, that's my Typodon. So I lent it because you know how you can get really nicely into the furcations and the distal portions of the model? That's what you'll be doing. Arrestin is tiny particles that are small grains of sand. They're not visible, and they're microscopic, and it's filled with minocycline. Now, did you see the actual yellow substance, or did you play with, you saw the actual yellow substance?
Yeah.
Okay, that's the minocycline that you saw. It's released slowly into the gingiva, surrounding the tooth, and it's perfect when it's working with scaling and root planing. Now, would you use Arrestin alone in a pocket without scaling and root planing? No. Why? Who wants to tell me?
The irritant is still in there.
What's that?
Because the irritant is still in there, so it's not going to promote.
Correct. And the endotoxins are still there. So when the root is clean, and then you place Arrestin in the pocket, then you're allowed to have some healing. Oops, got the wrong one. This is a chart that comes with the Arrestin, from Arrestin. You do not use this in clinic, but the reason I put this up is to show you here, after Arrestin is placed, after 1 week of treatment, what you could be explaining to the patient, what's going to be happening or they may find. And up to 10 days of the treatment, you do not want to water pick, floss the area. You can brush, okay? And they can brush the teeth all around it. Sometimes people say, well, I didn't want to go near the whole quadrant for 10 days. No, it's just that one particular site. So if you want to copy this or make a card from this, from the slide, and keep it in your notes, so this way you have it in clinic. Just a review, do not eat chewy, crunchy, sticky foods such as carrots, taffy, or gum for 1 week. Don't floss and clean that area, okay? Now, control release delivery devices is an antibacterial chemical embedded in the carrier material. Yes, Alexa?
I just said don't
Bless you.
or delay in that area, so they shouldn't be brushing that area.
They can brush, because remember, the bristles don't really get into proximal. You're basically using this into proximal. You're not going to really use this on the buccal and lingual. Why? Anyone? Because there's not a cold. The tissue's tight. Even though there may be a pocket, the tissue's tight. So you'll put it in and it'll squeeze it back out. So this is perfect for furcations, areas that are open that the medication can stay in that one area, okay? Or into around the bony defect around the tooth. The device is placed directly into the periodontal pocket. The carrier material dissolves slowly and produces a steady release of antimicrobial agent over a period of several days in the pocket, up to 10 days actually, more than several days. And chlorhexidine and antibiotic drugs are currently used. We're going to discuss the chlorhexidine coming up real soon. The rationale for use, the goal of this device is to subject subgingival bacteria to therapeutic levels of the drug for a period of several days. That's a very important statement because it's going right into that area. Now, you've been in clinic, has anyone come across this when you've done a scaling on a perio patient and you get done and the tissue looks really raw and doesn't look like it's, you say to yourself, gosh, what did I do? You didn't do anything. The disease did that. You're just removing the toxins. So when you place the Arrestin into that area, that will help also calm that area down. It will soothe that area to have it. So a good rationale to use Arrestin would be when you're done scaling and you're looking at the tissue and you're saying, maybe I should put Arrestin in here and I'll look a little bit better. Is that clear to everyone?
Yes.
And you don't want to, what's the minimum amount of pocket depth would you want to put any of these in? 5 millimeters or more. Okay. The benefit to control release delivery is results in small increase of attachment level in the periodontal pocket. What is it producing? What is that producing? When you have an increase of attachment level. Long junctional epithelium. Very good. That's what we always want to try to achieve. When you use for a long period, when used along the periodontal instrumentation, the results are better than they would be if you just use the Arrestin alone. Okay. We have, in the old days, we could all attest to this, right, Dee? Tetracycline fibers. We use minocycline, microsphere, doxycycline gel, and chlorhexidine gel. Well, now we no longer use the fibers. We no longer use the minocycline. Doxycycline maybe making a comeback, and the chlorhexidine chip has made a comeback. The tetracycline fibers, well, this took a half an hour to do. It was a long fiber, almost like a piece of floss, and we had to have a special packer, and it was full of tetracycline fiber, and we had to go back and forth, as you see, weaving it into the pocket. And then you leave a little piece of the tip out, and it used to sit in there for 7 days. It made it about a day. Sometimes they never even left the office and it was falling out. You would get a phone call that the fibers were coming. So this was discontinued because it was hard to use. It was very difficult and it had no ability to stay in the pocket. Minocycline microsphere was 2 syringes, used to attach it together and push it back and forth, and mix it. And they used to put a cannula on and inject it, as you see in the picture, in the pocket. It used to harden. The problem was, if the pocket, the picture here is a great pocket for it, because it would have stayed in that area. But when you had horizontal bone loss, and you put it into the pocket of the furcation, after a couple of days, the body automatically pushed it out, almost like a splinter. It pushed it out, and it used to be blue. And then people used to come in, is this what you put in my tooth? And, oh yes, that's a little sooner than 10 days. Okay, so that was said. Then we had the doxycycline gel. It was a great idea, but both the doxycycline and the chlorhexidine gel, which this is called the perio chip, were very difficult because they did not stay in. They were difficult to get in because they were so flimsy and thin that when you went to insert it into a pocket, if you had a pocket that was wide open, it was easy. But if you had a narrow pocket, it used to bend, and the minute it got wet, you couldn't use it any longer. So the gel chip is back. We are using it. There's a study right now. By next week is the American Academy of Periodontology this weekend, and they're talking about using this for periimplantitis and mucositis. Because it's so thin, it can get into that area, and because usually the threads of an implant are exposed at that time, it has something to adhere to, opposed to a smooth glass-like tube. So in the upcoming year, we'll find out more about the perio chip. But as this says, it's difficult to maneuver, to get into the pocket, and the chip would dissolve. That was the benefit of it. When it stayed in, it would dissolve and you didn't have to remove it. All right, but since chlorhexidine is not an antibiotic, there's no risk of an antibiotic resistance to the gel of the chip. That's why it became very popular, very fast. As soon as it came on the market, everybody bought it. It was the savior drug. But it wasn't. It had its drawbacks. But the resurgence of it is, I think they changed the formula. They made it a little thicker to stay in. Okay, so let's recap on this. We talked about the different types of antibiotics that we use and we used to use in the pocket. And these devices are subject to subjugable bacteria. Therapeutic levels of the drug are sustainable for a period of time, a week. So right now, I would say the one that we are using mostly is the minocycline, is the Arrestin, and that's the one you'll be using in clinic. Does anyone have any questions on the Arrestin or anything else we discussed so far? No? Let's get into my favorite topic, host modulation. Why is this my favorite topic? You okay, Aisha?
Yeah, thank you. Yeah.
Host modulation is the future, is your future. It started about maybe 15 years ago, that host modulation was brought up. And a lot of research has been done in this, and there's a lot of research being done right now. And next year, the AAP meeting in Boston, I believe there's going to be a speaker speaking about the new therapies for host modulation. So what is host modulation? Well, let's go over the objectives first. Host modulation. What is the definition of host modulation? We'll review that. What is the response of modulation? What agents are potential hosts from host modulation? How does host modulation fit in the comprehensive periodontal management? Those are good questions. Let's start with host modulation and periodontitis. This is what it is. It's alternating the patient's defense response to help the body limit the damage to the periodontium from infection such as periodontitis. Isn't that the key? If we could do this, we have a lot less perio. But there's some drawbacks. We'll get into that. Host modulation response to periodontal pathogens in major contribution to disease pathogenesis. Modulation of the host defense is currently an important focus for periodontal research. This is your future. Now, I've also posted on Canvas a report. I don't know if anyone got a chance to read it. You didn't have to read the whole thing. Just the first 3 pages what is important. This is the report. It speaks about host modulation. And to quote the author of this, ultimately, it's the host's reaction to the presence of bacteria that mediates the tissue destruction. Now, 2 weeks ago, we discussed what the difference is between osteoclast and osteoblast. Can anyone tell me the difference? What's osteoclast? Right, osteoblast. Okay. So we all know that somewhere in our body is triggered for the people who have periodontal disease and the people who don't have periodontal disease. We know that something triggers the osteoclast to destroy the bone. Now we know that there's certain etiology factors and there's certain things, genetics, that go along with it. But wouldn't it be great if we could figure out how to stop that? And that's what host modulation is. Since the destruction of periodontal tissue is believed to be due to the host response, it is logical to consider therapeutic approaches that modulate the host response, in addition to antibacterial approaches in the management of periodontitis and peri-implantitis. This is all in your slide. So this is an important statement because this is saying, this is like a hypothesis. Imagine if we could figure out how to prevent the osteoclast from getting destructive. A number of host modulation agents have been investigated, which include non-steroidal anti-inflammatory drugs, antimicrobial dose of doxycycline, and biphosphorates. Now, I spoke to Ms. Zaworski, in pharmacology. You did not go over biphosphorates, so we're going to go over them today. But you did go over NSAIDs to extent. Okay, good, and you went over antibiotics. The primary etiology of periodontal disease and chronic inflammation around dental implants is bacterial infection. We all know that. In essence, a gram-negative infection of the pocket is necessary, but not significant to induce periodontal disease of the process. Ultimately, the host reaction to the presence of bacteria mediates tissue destruction. The response could be influenced by environmental, tobacco, and other things, acquired, systemic, and genetic risk factors. I think that's a really, really, really important statement that I would really take note of, that really, really important statement on number 3. Okay? Really take note of it. Let's talk this through. How many patients have we seen that are full of bacteria? They have no pocket depth. Yes, they have gingivitis, but they don't have pocket depth. Has anyone seen any of those patients in the clinic?
Yes.
And you say to yourself, wow, did I probe this patient right? Is this possible that they have no pocket depth? Because their response, their host response is not to this bacteria, does not cause periodontal disease. Now, they may smoke and they may have other things, but they just happen to be lucky that the genetic risk factors are low for periodontal disease. Periodontitis is initiated by plaque bacteria. It's characterized as destructive of the periodontal ligament and bone. We all know that, right? Alveolar bone resorbs, occurs, results in uncoupling of abnormal balance in the process of the bone and resorbed in bone formation. Osteo what? Class. Okay, here we go with the osteoclast. Cytokines. You remember this from chapter, I think it was 7 in Foundations of Perio? You studied this first year? Cytokines, chemokines, and prostaglandins. You remember those guys?
Yes.
Okay. They have been identified as the regulators of the immune inflammatory process in periodontitis. As a matter of fact, there's a culture that we do that tests for these disorders, because there are people that want to know if they have a genetic response to periodontal disease. So this company came out with this, that they test the interleukin-1 to see if they have the factors that can cause osteoclast formation. The purpose of host modulation therapy is to restore the balance between, on one hand, pro-inflammatory mediators and destructive enzymes, and on the other hand, anti-inflammatory mediators and enzyme inhibitors. That's a big sentence. So what this sentence is telling us is that what host modulation does, it restores the environment. It's like your soldiers. It's your soldiers fighting the war against cytotoxins, proglastins, immune regulators, interleukin-1. We have to fight. Potential host modulation agents. Well, we have doxycycline. We have tetracycline also. We have NSAIDs. We have biphosphorates, stain medication, dietary supplements, and other agents that are under investigation right now. But what we're going to be focusing on is basically 3. These are the 3 most important. Doxycycline as a modulation agent. Okay, this is a very important definition, so it's very important. Okay? Definition of sub-antibacterial. This is not subgingival. I don't want to see that on the test written anywhere. This is sub-antibacterial. The dose of antibiotics, regular antibiotics, the dose of antibiotics are below the normal bacteria killing and inhibiting dose. So, if you take 1,000 milligrams of doxycycline for acne, and you take 20 milligrams for host modulation, there's a difference in the response, isn't there? It's not eating on your immune system, it's focusing on one particular area that responds to doxycycline. So these antibiotics are low concentrate given for a long period of time. And as of right now, doxycycline is the only one that's being used. So it's an antibacterial dose, is the higher dose that kills bacteria, but the sub-antibacterial dose is slow and low. What is it? Slow and low. Okay? It's 20 milligrams, it's called Periostat. Now, this is used off-label. Periostat, the FDA has approved Periostat 15 years ago for patients to take a low dose. When it's marketed as Periostat, it's very expensive. So what happens a lot of times that in the past, dentists would write, or physicians would write a prescription for doxycycline, just write a prescription for doxycycline 20 milligrams and give a long dose because they take it twice a day for 9 to 12 months. Now, what is something that would be a problem for a patient to take that for that long period of time? Anyone? Resistance? Well, not really, because it's a low dose, so it's not going to cause GI problems or other problems like that. The problem is compliance. Major problem with this drug, because we tried this on many of our patients, and they said, "Oh, I didn't think it was doing anything, so I stopped it." Well, that's a major problem. So what in the future, if it comes out that doxycycline is going to be used as a host modulator, it's going to have to be instructed to the patient that they have to continue to use it, even though, you may not see the results, but you're going to see the bone regrow. Doxycycline has other effects in addition to the antibiotic effects. It's a sub-antibacterial dose. It decreases the effects of the enzyme collagenase, one of the matrix, and it causes and can cause breakdown of the periodontal tissue. If you do the MMP, you studied that the first year, right? Okay. That causes the breakdown of the tissue. So what this does is it stops it, that breakdown of the tissue. Oops, hit the wrong button. Since doxycycline, oh, this is a really nice slide. Maybe you should note this one. Since doxycycline at a sub-antibacterial dose alters the body's defense by inhibiting part of the destruction, it can occur in periodontal disease. This is considered a host modulation agent. This is being studied right now as one of the host modulation agents. These are to be used together. The other ones we're going to go over. This is not just take a pill, you're going to regrow new bone, the osteoblasts are going to start building new bone. No, it's the whole thing of working together. And it's to stop the breakdown of the bone loss. See, so important, I underlined it. The FDA approved sub-antibacterial dose of doxycycline, it's called Periostat, for twice a day, used in treating patients with periodontal disease. No antibacterial effects on the oral bacteria or bacteria in other parts of the body have been found to use in low-dose doxycycline. So if you have a patient who's on doxycycline for acne, that's a very popular one. I don't know if anybody's ever been on doxycycline for acne. It's a very popular drug, but it's a much higher dose, doxycycline for acne. So So some people say, oh, is this gonna clear up my face? No, it's not gonna clear up your face. Because clear up your face is at 500 milligrams. This is 20, a little different. Studies have shown reductions in probing depth and gain in clinical attachment levels, as well as prevention of periodontal disease progression with the use of low-dose doxycycline. That's what it's all about. You're getting a healthy pocket, you're getting long junctional epithelium, you're suppressing that bacteria from, that gram-negative bacteria from being destructive. Chemical modified tetracyclines. Lack of antibacterial agent, but have potential as a host modulator. Inhibit destruction of mediators. Oh boy, is that important? Yes. Because if that if we could stop the osteoclast, we're in good shape. Bone resorption can be suppressed. It won't hurt the GI, and it's currently, like I said, being reinvestigated. This is your future. Now let's talk about the NSAIDs. You all know these names, right? You studied them last year in pharmacology? All right, these are the NSAIDs we're talking about. This is just a review. NSAID can reduce tissue inflammation by inhibiting the prostaglandins, including PGE2. NSAIDs can inhibit osteoclast activity. Yes, let's get rid of those guys. Some NSAIDs, when administered daily over 3 years, can cause a slower rate of alveolar bone loss associated with periodontal disease. But what are the drawbacks of NSAIDs? The drawbacks. What is the drawback of being on NSAIDs for a long period of time? Bleeding ulcers, right? Kidney problems, liver problems, liver toxicity. These are all problems. So, as an NSAID being used as a host modulator is a great idea, but it's not for a long time use. It's for a short time use. So if a patient comes in and is having periodontal surgery, or we're doing initial scaling, they may be put, as a part of the host modulation, they may be put on an NSAID for a short period of time, just to help, but not for a long period of time, like the doxycycline is. The purpose. At the present, there are no NSAIDs that are approved for treatment of periodontal disease at this time. Intensive research has involved the use of drugs for periodontal patients. So right now, we don't know. Biphosphorus. Okay, so everyone take one of these and pass it down. This is a list of different biphosphorus drugs that they can, or if you want to, someone want to hand them out. Can you hand them out? Yes.
My question is, like, when you condition doxycycline, is to reduce the bacterial reactions or interactions, right? And then when you take the NSAID, is to keep the inflammation at a certain level.
Yes.
To
They
help
work
with
hand in
resorption.
hand. Right.
To help with resorption, right?
Right. So what the antibiotic is doing is keeping the bacterial level low in the pocket and allowing the osteoblast to do their thing, to remodulate the bone. What the NSAIDs are doing is to reduce the inflammation, so this way the bacteria can be reduced also. But who has the most important part in all this? Right, why? What? Home care. Patient has to keep the bacteria out. Patient has to stop. What is the ideal time to break up the bacteria? 12 hours. That's when we go from being, before the bad bacteria are allowed to absorb with the gram-positive bacteria. So 12 hours. So what would be the first thing, if this is approved and you're working for a periodontist And the periodontist, what's the first thing you're gonna do with that patient?